Good morning, everyone. I am Dr. Lata, Professor of Physiology, Sri Lakshminarayana Institute of Medical Sciences, Puducherry. Today, I am going to explain about antihemostatic mechanism. So, antihemostatic, in the name itself, it is given, it prevents the blood clotting. Hemostatic means blood clotting, and antihemostatic means it prevents the blood clotting. The antihemostatic factors normally discussed under three headings: factors preventing platelet aggregation, factors preventing coagulation, factors causing fibrinolysis. So, factors preventing platelet aggregation. So, what is platelet aggregation? So, it is one of the important steps in the hemostasis. So, some of the factors, it prevents the platelet aggregations so that it prevents the blood clotting. So, mainly two factors that prevents the platelet aggregation: prostacyclin and aspirin. So, both prostacyclin and aspirin, the mechanism of action is same. Prostacyclin is endogenous factor and it inhibit both prostacyclin and aspirin inhibit thromboxane A2 formation, so that it prevents the intravascular spreading of platelet plaque. So the aspirin, it has important features. It prevents the thrombosis in patient prone to myocardial infarction and stroke. So aspirin, it is mainly used in patient those who prone to myocardial infarction and stroke. Circulatory anticoagulants: heparin, antithrombin 3, and protein C. So heparin, it is first isolated from liver. So in the name, that's why it is called heparin. It is a polysaccharide containing many sulfate groups. The molecular weight of the heparin is 15,000 to 18,000 Dalton. The secretions, normally the heparin is secreted by the basophils and mast cells. And the heparin is destructed by the enzyme heparinase present in the liver. The main functions of the heparin are maintains fluidity of the circulating blood and prevents the spread of intravascular thrombosis after trauma. The mechanism of action of the heparin, or it prevents the activation of prothrombin to thrombin. So in the hemostatic mechanism, so it is one of the important steps, the conversion of prothrombin into thrombin. So heparin, it prevents the conversion of prothrombin into thrombin. And next, it inhibits the action of thrombin on fibrinogen. So what the thrombin will do, it converts fibrinogen into fibrin. So the heparin prevents the conversion of prothrombin into thrombin, and also it prevents the action of the thrombin, inhibits the action of the thrombin on the fibrinogen. And third thing, it facilitates the action of antithrombin 3. So antithrombin is nothing but it is one of the anti-clotting factors. It is present in the plasma and vascular endothelium. It inactivates number of coagulation factors, including thrombin. The action is facilitated by heparin. So next, thrombomodulin. So thrombomodulin, it is one of the thrombin binding protein produced by all endothelial cells except those in the cerebral circulation. The main action of thrombomodulin is it converts thrombin to protein C activator. Next, protein C, the plasma proteins. Protein C is a plasma protein synthesized in the liver. Along with the thrombomodulin, It constitutes the negative feedback mechanism. Protein C activated by protein C activator and protein S. So after activation, the activated protein C inactivates the clotting factors, mainly 8 and 5, so that it inhibits the clotting mechanism. And also it inhibits the fibrinolysis by promoting the plasmin formation. So thrombin, it is converted into protein C activator. So with the action of the protein S, the protein C activator acts on the protein C and convert that into activated protein C. This activated protein C inactivates factors 8 actually, 8 and 5 and plasminogen. It activates activators that prevents the conversion of plasminogen into plasmin. Fibrinolytic mechanism, the process that brings about the dissolution of fibrin. So first one is plasmin. It is a powerful protease present in inactive form. Plasminogen. The main action of the plasmin is lysis of blood clot. Reopening of the blood vessels, so that it reopening the blood vessels. So because of blood clot, the blood vessel is occluded. Okay, so it causes reopening of the, it causes lysis of the blood vessel, so that it reopening the lysis of the blood clot, so that it causes the reopening of the blood vessels, blocked blood vessels. In the absence of plasminogen, the wound healing is delayed, and it plays important role in, so that it plays important role in growth and fertility. So next, tissue plasminogen activator. It is released from endothelium. Release depends upon the serotonin and adrenaline. Stress and exercise. During stress and exercise, sympathetic system is activated that releases adrenaline. That in turn increases the tissue plasminogen activator release. It is also synthesized by recombinant DNA technology. It lyses the clot in the coronary arteries if given soon after the myocardial infarction. Fibrinolytic mechanism, plasminogen, so converted into plasmin by the action of the tissue plasminogen activator. Okay. So this plasmin, it is converted into, so it acts on the fibrin and prevents the, okay, it acts on the fibrin and converts that, split that fibrin into fibrin degradation products. So injured vascular endothelial cells, plasminogen activators. Okay, this plasminogen activators act on the plasminogen and convert that into plasmin. The plasmin acts on the fibrin and convert that into fibrin degradation product. Physiological role of fibrinolytic system. So what are the physiological role? Cleaning the minute clots of tiny blood vessels, promote normal healing process, liquefaction of menstrual clot, liquefaction of semen, role in inflammatory response. So because of this fibrin degradation products, it split the fibrins, it cleans the minute clots of the tiny blood vessels and promote normal healing process. Liquefaction of menstrual clot, liquefaction of semen, and role in inflammatory response. So next, anticoagulants. So anticoagulants are nothing but they are the substance which delay or prevent the process of coagulation of blood. Endogenous anticoagulants, there are two types, endogenous anticoagulants and exogenous anticoagulants. Endo, inside. So anticoagulants formed within the body. So endogenous anticoagulants are heparin, antithrombin 3, protein C. Exogenous anticoagulants are heparin, calcium sequesters, vitamin K antagonist, and defibrillation substances. Calcium sequesters are decalcifying factors. These factors prevent the blood clotting by sequestering the calcium from the blood by forming the insoluble salt with calcium. Example for the decalcifying factors are sodium citrate, sodium oxalate, and EDTA. So next, anticoagulants are vitamin K antagonist. So the anticoagulants comes under this category are coumarin derivatives, warfarin, phenydione, nicomalone. Okay. So mechanism of action. It binds the vitamin K receptors in the liver and prevents the synthesis of vitamin K dependent clotting factors. Mainly factors 7, 9 and 10. So next, defibrillation substances. It causes the destruction of fibrinogen. Example, Malaysian pit viper venom, Arvin or Ancod. Bleeding disorders, persistent or excessive bleeding following the minor injuries. So classification of the bleeding disorder. So bleeding disorders are classified under 3 headings: due to platelet disorder, due to coagulation disorder, and due to vascular disorder. The platelet disorder may be due to deficiency of platelet. The platelet disorder. So in that, if it is due to deficiency of platelet, that condition is called thrombocytopenic purpura, and functional disorders of platelet, thrombocytopenic purpura. Due to coagulation disorder, that is maybe due to deficiency of clotting factors, vitamin K deficiency, anticoagulant overdose, disseminated intravascular clotting. And next, due to vascular disorder, due to infection by bacteria and the toxins, due to toxic effects of drugs and chemicals, due to avitaminosis, allergic purpura, connective tissue disease. So next, purpura. Purpura, it is first one is thrombocytopenic purpura. When the platelet count is below 1.5 lakh per cubic millimeter, the purple color petechial hemorrhages and bruises appears in the skin. So there are two types of thrombocytopenic purpura, primary and secondary. The primary thrombocytopenic purpura, the cause is idiopathic, and secondary it is due to bone marrow depression, leukemia, acute septicemia, toxemia, and uremia. The primary may be due to immune defect, that is called immune thrombocytopenic purpura. So in this picture, you can see red color petechial hemorrhages on the skin. Okay, this is thrombocytopenic purpura. Platelet count and bleeding. When the platelet count is above 1 lakh per cubic millimeter, no clinical symptoms of bleeding. When the count is between 50,000 to 1 lakh cubic millimeter, bleeding may occur after major surgery. So when the platelet count Between 20,000 to 50,000 per cubic millimeter, bleeding occurs with minor trauma. When platelet count becomes less than 20,000 per cubic millimeter, spontaneous hemorrhages in the urinary tract, gastrointestinal tract, nosebleeds, etc. We can see that at the low count, we can see fatal hemorrhages in the brain. Thrombocytopenic purpura. So thrombocytopenic purpura, thrombocytopenic purpura means when the platelet count is decreases, that time we can see the purplish petechial hemorrhages. So in this thrombocytopenic purpura, the platelet count is normal, but the functional platelet number is decreased. Functions of the platelet is decreased. So it is the functional disorders of platelet. So this thrombocytopenic purpura characterized by prolonged bleeding with a normal platelet count. The causes for the thrombocytopenic purpura are drug-induced defects. So like aspirin. Okay, for example, aspirin, large doses of penicillin and other drugs. Next cause for this von Willebrand disease, it is an autosomal dominant trait. Deficiency of factor 8 related antigen. So it acts as a carrier of factor 8. So other causes for the thrombocytopenic purpura are uremia, cirrhosis, and leukemia. So vascular disorders, non-thrombocytopenic purpura, the causes for the non-thrombocytopenic purpura are drug-induced damage to the capillary wall. So for example, corticosteroids, penicillin, sulfa drugs, and aspirin. And second cause is deficiency of vitamin C. It leads to failure of collagen formation and impaired hydroxyproline synthesis. And third one is scurvy due to decreased intracellular substances and less stable capillary membrane. And fourth is damage to the capillary wall by antigens. That is called allergic purpura. And fifth cause is infections like typhus, bacterial endocarditis, streptococcus. So next, senile purpura. Purpuric hemorrhagic spots seen on the back of the hands and forearm due to prolonged pressure or trauma. So normally the senile purpura, the name itself, it indicated senile. So normally it occurs in old age. So next one is hemophilia. So hereditary deficiency of clotting factors. Hemophilia, it is due to hereditary deficiency of clotting factors. There are three types: hemophilia A, B, and C. Hemophilia A is 83%, hemophilia B is 15%, and hemophilia C is 2%. So first, hemophilia A, it is a sex-linked recessive disorder. It is mainly due to factor 8 deficiency. So because of this, clotting time is prolonged. It affects the males and females. It affects the males and females are the carriers. So when the hemophilic male and crossing with a carrier female, the progeny will be hemophilic female. Hemophilics have tendency to bleed into soft tissues, muscle, joints, etc. Joints are severely damaged due to repeated hemorrhage. Have normal bleeding time. So in this hemophilia A, have normal bleeding time, platelet count, and prothrombin time. The treatment for the hemophilia is repeated transfusion of small amount of fresh blood or plasma within half an hour of collection. Factor 8 and also administering the factor 8 concentrate. Next, hemophilia B, that is due to deficiency of Christmas factor, that is factor 9. Hemophilia C, it is due to deficiency of factor 11. So next one is disseminated intravascular coagulation. It is a widespread intravascular coagulation. So in which the clotting mechanism activated in widespread areas of the circulation. So plugging of the small vessels with the clot. So because of this plugging of the small vessels with the clotting occurs, that decreases the oxygen and nutrient supply. So this leads to multiple organ damage. Failure of the hemostatic mechanism due to non-availability of clotting factors and platelets. So this condition is called conception coagulopathy. Disseminated intravascular coagulation associated with septicemic shock, prolonged postpartum hemorrhage, snake bite, etc. So the pathogenesis, this chart shows the pathogenesis of disseminated intravascular clotting. It may be due to activation of intravascular coagulation or endothelial damage. So first, activation of intravascular coagulation may be due to platelet consumption, coagulation factor consumption, and fibrinolysis. So because of platelet consumption, decreases the platelet, coagulation factor consumption, increased prothrombin time, and activated prothrombin time. Then fibrinolysis, due to fibrinolysis, the D-dimer level is increased. These all leads to impaired coagulation and bleeding. So next, endothelial damage. So because of the endothelial damage, microvascular thrombosis occurs. It leads to multi-organ ischemia. So next, laboratory test for the bleeding disorders. Bleeding time, capillary fragility test, platelet count, clotting time, prothrombin time, thromboplastin, generation test. So bleeding time. So normally in the labs, we used to do bleeding time and clotting time. So in the bleeding time, we are using the Duke's method, and clotting time, capillary tube method. So in the bleeding time, for every 30 minutes, we have to puncture the skin, and we have to start the timer. And for every 30 seconds, we have to place a drop of blood on the filter paper till the blood stops. And we have to now count the number of drops of the blood and multiplied with half. That will give your bleeding time. The normal bleeding time is 1 to 5 minutes, and the clotting time is 2 to 8 minutes. So once again, I will refresh this. So we have discussed about antihemostatic factors. So it is classified under, it is discussed under 3 headings. Factors preventing platelet aggregation, factors preventing coagulation, and factors causing fibrinolysis. So factors preventing platelet aggregation are prostacyclin and aspirin. So both inhibits the thromboxane A2 formation. Circulatory anticoagulants are heparin, antithrombin 3, and protein C. So heparin, it prevents the activation of prothrombin to thrombin and inhibits the action of thrombin on the fibrinogen and facilitate the action of antithrombin 3. So antithrombin, it is a protein present in plasma and vascular endothelium. So what it will do, it inactivates number of coagulation factors and also thrombin. It is facilitated by heparin. And next one, thrombomodeling. It is a thrombin binding protein. It converts thrombin into protein C activator. When it binds to thrombin, it converts into protein C activator. So protein C, one of the anti-clotting factors. So that is synthesized in the liver. Okay. And so normally thrombomodulin, it binds with the thrombin, convert that into protein C activator. So that protein C activator acts on the protein C and convert that into protein C. So this, what it will do, it inhibits the conversion of, one second. Oh, sorry, it activates the conversion of plasminogen into plasmin. So next one, fibrinolytic mechanism. So third one, fibrinolytic mechanism. So in this mainly, the main substances involved are plasmin and tissue plasminogen activator. So plasmin, we all know that. So it acts on the fibrin and break down the fibrin and converts that into fibrin degradation product. So tissue plasminogen activator. So what it will do? It activates the plasminogen and converts that into plasmin. So plasminogen, it is converted into plasmin by tissue plasminogen activator. So this plasmin acts on the fibrin and converts that into fibrin degradation product. So next, physiological role of the fibrinolytic system. So we have discussed what are the roles of the fibrinolytic system. Cleaning, so what it will do, it cleaning the minute clots, promotes a normal healing process, and it also helps in the liquefaction of menstrual clot and semen, and it also plays important role in the inflammatory response by forming the kinins. So anticoagulants, there are two types, endogenous and exogenous. Endo means it formed inside and exogenous it forms outside. So endogenous are heparin, antithrombin 3 and protein C. So we all know that already we have discussed about heparin. So what it will do, it converts, it inhibits the conversion of prothrombin into thrombin, and also it inhibits the action of the thrombin on the fibrinogen, and it facilitates the antithrombin 3. So antithrombin 3, and next one is protein C. So protein C, it acts on the, it converts the plasminogen into plasmin, and the plasmin acts on the fibrinogen and convert that into fibrin degradation product. So exogenous, it prevents the blood clotting by sequestering the calcium. So the calcium sequesters are sodium citrate, sodium oxalate, and EDTA. Vitamin K antagonist are coumarin derivatives, warfarin, phenydione, necomolone. Okay, this vitamin K antagonist bind to vitamin K receptor in the liver and prevents the synthesis of vitamin K dependent clotting factors. So next, defibrillation substances. Okay. Those are Malaysian pit viper venom and Arvin and Arcad. This causes destruction of the fibrin. After that, we have discussed about bleeding disorders. So bleeding disorders mainly due to platelet disorder, coagulation disorder, and vascular disorder. Okay, platelet disorder, there are decreased number of platelets and non-function of the platelets. So due to decreased number of platelets, that condition is called, it produces purple color petechial hemorrhages. Okay. So that is called thrombocytopenic purpura, and the functional disorders of the platelet is called thrombasthenic purpura, and vascular disorders that is called non-thrombocytopenic purpura. So the non-thrombocytopenic purpura are due to drug-induced damage to the capillary wall, deficiency of vitamin C, scurvy, damage to the capillary wall by antigen, and infection. Next, senile purpura, it occurs in old age. Purpuric hemorrhages occurs in old age. So next we have discussed about hemophilia. Hemophilia A, B, C. A is due to factor 8 deficiency, B is due to factor 9 deficiency, and C is due to factor 11 deficiency. The treatment for the hemophilia, repeated transfusion of small fresh blood or plasma within half an hour of collection. And also for B, administration of factor 8 concentrator. So next, disseminated intravascular clotting. So it is nothing but widespread intravascular coagulation. So occurs, okay. So this leads to plugging of the small blood vessels and finally leads to multiple organ damage. In some cases, failure of the hemostatic mechanism due to non-availability of clotting factors and platelets that usually seen in conception coagulopathy. So laboratory test of bleeding time, capillary fragility test, platelet count, clotting time, prothrombin time, and thromboplastin generation test. Thank you.